Good evening, doctors. I'm Dr. Namra Sheikh, medical advisor with Emcure Pharmaceuticals. I welcome you all on this digital platform for another exciting session on no thrombosis workshop series in stroke. It gives me immense pleasure to welcome our course director for today's session, who is Dr. Pichaporia, sir. Sir is the director of the Neurology Department, Sahyadri Hospital, Nagar Road at Pune. Sir has set up the first neuro ICU and neuro-intensive care of Pune. He has been a pioneer in stroke treatment for thrombolysis, has the credit of delivering 300 public lectures and workshops on stroke, is the founder of the Pune Stroke Group, and has been the principal investigator for multiple international and stroke trials, and has been awarded as a health icon by the Times of India Group. We welcome you, sir, today. Thank you for being on board.
Thank you. Thank you so much.
Hello, sir. Good evening.
Good evening. Good evening. Good evening, Dr. Sinha.
Our moderator for today's session is Dr. Rahul Baviskar. Sir is senior consultant neurologist at Sahyadri Hospital, Nashik. He has an experience of over 30 years as a consultant neurophysician at Nashik. He has interests in management of headache, epilepsy, stroke, dementia, and multiple sclerosis.
Shall I start slide presentation?
Yeah, please.
Just a minute, Dr. Namra. I think there's some problem there. Welcome, Dr. Baviskar.
Yes, sir. Good evening.
Good evening.
Yeah.
Dr. Sinha is already there.
Yeah, good
Good
evening,
evening, Dr. Sinha.
Baviskar,
Yeah.
Tushar,
I think we've lost her.
Patel.
Okay. Dr. Tushar, I think instead of wasting time, why don't you start?
Yeah, I will start then.
Yeah.
Are you able to see the slides?
Not yet. Yes, yes. Now we can.
You can see the slides?
Yes, we can see and hear you.
Okay. Okay. Good evening, everyone. I am today going to present an unusual case of quadriplegia. And the history is something like this. She is a 12-year-old female child presented without any previous...
Little loudly, please.
Okay. She is a 12-year-old female child without any previous illness. She has presented with complaints of sudden onset weakness of all four limbs since 2 days with fecal and urinary incontinence. And there was no history of any numbness or tingling sensation involving the limb surface. There was no history of any swallowing difficulty, coughing, or speaking. There was no history of any headache, loss of consciousness, or seizures. No history of any recent fever, cough, common cold, or loose motions. No history of any blurred vision. No history of any rashes, recent vaccination, or travel. On examination, the patient was conscious-oriented, vital space stable. There was no cranial nerve deficit. There was decreased tone in all four limbs. And power was 0 to 1/5 in all four limbs, including truncal weakness. Reflexes were absent. Plantars were bilaterally mute. On the examination, JPS touch was normal on initial examination. So initially, I thought that if there is such was rapid presentation within 2 days, my first thought was probably she may be a case of very GBS, but the odd point was she has fecal and urinary incontinence. That was the only odd point for her. Any comments from your side, sir, suspected for the
Dr. Sinha?
Yeah, since it is a acute onset quadriparesis without any sensory involvement, it is more likely the anterior part of the cord is involved. And then it is sparing your bulbar muscles.
Yeah.
So everything is below. The respiration is intact, swallowing is intact. You said cranial nerve is normal. I assume that she is able to talk normally.
Yeah.
Her consciousness is okay. So when the whole ARSS system is intact. So everything, and then the bladder bowel is affected. So
Yeah.
that will go in something like anterior spinal syndrome of acute onset, because that's how I would read it.
Yeah.
Dr. Bhaviskar?
I think I agree with that. Relatively acute onset, sudden quadriplegia, and anterior cord presentation. So vascular event involving the anterior spinal artery is the most likely diagnosis. Another etiologies, like he said, GBS, sometimes acute transverse myelitis can present sometimes with this, considering the acute presentation relatively over 2 days. But certain odd features like no sensory level, that is relatively odd. No sensory features per se is relatively odd for acute transverse myelitis.
Yeah.
Any neck manipulation was done?
Yes, sir.
Any neck manipulation or injury?
No, initial history, there was no history of any neck manipulation, sir.
And later history?
Later history, I will come down to the later history, sir.
Okay.
The upper limbs, what was the shoulder?
No, you have to ask specifically.
Yeah, the shoulder was okay, or
Yes.
only which area was the more weakness?
Both, so actually the power was 0/5, 0 to almost 1/5 at presentation.
Shoulder also.
Yeah.
So it is not the thoracic where we get usual anterior spinal artery syndrome. It's a higher up.
Generally, Adamkiewicz.
Something vascular is one possibility. Any vasculitis, any compressive lesion, but there is no pain in the spine.
Later, I will come down to the later about it, sir.
Okay, fine. So this is what is a localization.
Yeah.
Now etiology could be infective.
Yeah.
Because acute.
It can be acute, sir. I will just show the initial images. What were the images actually?
Yeah. Very interesting.
So as per the discussion, it was most likely my diagnosis was also like that it was maybe a anterior spinal artery syndrome. Even the MRI images also showing the linear hyperintensity in the cervical as well dorsal spine along the anterior aspect. Which was seen.
Very long segment.
Yeah, it was very long segment.
Typically anterior part.
Yeah.
Any axial cuts?
So though there are no axial cuts as such, I have only sagittal cuts. I have an axial cut of another images. I will show it to you. This was the T1 sagittal. T1 sagittal didn't show any such specific abnormality.
Okay.
This
and no visual symptom.
No
visual loss
also,
or any...
the hyperintensity along the anterior aspect of the spinal cord, along the cervical also region. Lower cervical and dorsal region. This was the T1 plus contrast image. T plus contrast image also shows the linear hyperintensity along the cervical dorsal region.
Okay. CSF.
Yeah, I will show the CSF also. Sir. So anything about the images? Anything you would like to comment about the images?
It is respecting the anterior part of the cord. It is sparing the posterior part, where generally vulnerable by demyelinating disease.
Okay.
One thing. Second
You
thing,
have any DWI image?
Any second thing, whether the person has any other history of sickle cell disease or anything like that. She's a young girl. That's also
there was no history of any previous illness, sir. No history, no hematological disorder.
Yeah. And then we should also think about aquaporin 4 in this case because very long segment coming acutely.
Yeah. One thing I would like to point out in the sagittal images, sir. If you see the sagittal images, there is subtle hyperintensity in the vertebral bodies also. If you can carefully see.
Yeah,
Yes.
Are you able to see, sir?
I can see that, but how much significance we place on that?
Here you can see even the
It is-
intervertebral disc also a little subtle hyperintense are there.
Okay.
Here you can make out here also, sir.
Yeah, that particular body is
Yes,
there, yeah.
yes.
So then it will give some kind of but no neck problem, no neck pain. Otherwise, you can think about tubercular lesion or any inflammatory lesion of the spinal cord, I would say the vertebra, which is spreading in the cord, in this space, and affecting the anterior spinal artery, like secondary involvement of the vessel. But yeah, it's a nice pickup that, yeah, there is a vertebral lesion. But clinically, you didn't say anything about the neck pain.
Yeah, I would
Whether that part of the vertebral body is also supplied by anterior spinal artery branches, something like that.
Yeah, the part of the vertebral body is also supplied by the ASA also. And I would like to say that about the neck pain part, on initial, when I was taking history as well as doing examination, she didn't say anything about the neck pain, but on the later part, she complained about the severe neck pain to me. The parents told me about she had initial neck pain.
Okay, beautiful. Good.
Other possibility is discogenic emboli into the anterior spinal artery because of, emboli from the disc. You said something is wrong with the disc. No, I can't see it very clearly. But discogenic emboli is another possibility.
Yeah, absolutely. That's the one entity, but mostly they have described in cases of extruded disc.
Extruded disc going into anterior spinal artery.
Post-traumatic.
Yeah.
No history of trauma in this case.
So the repeat, whenever I have taken the repeat history, she has specifically mentioned that she has lifted a jar of 50 liter of water overhead.
Okay.
Overhead.
See the trauma in the neck.
48 hours before the onset of the symptoms.
See, the trivial trauma many times they lead to inflammatory lesion or abscesses.
So then it's likely to be discogenic emboli.
Yeah. That those seconds could be pyogenic inflammation also. Could
No, but
be
there's no fever, sir.
No illness, sir. No previous illness.
What about dissection?
Fever may not be there in many cases. Epidural, but there is no definite epidural collection here.
I will just show the next slides.
Okay.
This was the radiological findings. As already discussed, probably after the clinching point here is that she has lifted a jar of water overhead. And after 2 days after that, she had developed the symptoms.
Okay.
Patient had severe neck pain, as already told. 2 days before the onset of symptoms, neck pain developed after she had lifted a jar of water approximately 15 liters overhead. This was the only clinching history again I have got after repeating the history and examination. And in repeat examination also, there was a definite sensory level up to the T4 was there. Pinprick loss was there on repeat examination.
Okay.
So the summary was 12-year-old female who has presented with complaints of neck pain, followed by sudden onset quadriplegia with bladder and bowel involvement, with sudden pain and temperature loss with definite sensory level at T4, and suggestive of involvement of corticospinal tract and spinothalamic tract.
Okay.
So in the differential diagnosis, I kept most likely acute myelitis. It can be a vascular cause. In the vascular, it was either infarct, a fibrocartilaginous embolism, or hematoma. These were already ruled out, or it can be a structural cause, that is spinal cord injury or a surface myelopathy, which is due to the hyperextension of the back, or subacute myelitis, that is inflammatory demyelinating disorders or infectious causes. So I worked up for this also. These were the blood reports of the patients. The CBC was normal, LFT, RFT was normal, TSH and triple H was also normal. Even VDRL was done. VDRL was also normal. This was her CSF. The CSF was also normal. There was no such abnormality. I also did ANA, ABLA, VDRL, NMO, and MOG was sent, which was negative. Chest X-ray, ECG, and echo was normal. MRI brain with stroke protocol was also done, which was normal. Lyme's antibody was not sent. This was the spinal MRI DWADC, which was done after few days, after 2 days.
I can't make out much in this.
This is axial.
Yes, sir, this is axial.
You have the sagittal in this?
No, sir, I have axial. If you can see, sir, there is a hyperintensity there
Yeah.
in the anti-aspect of the
So
spine.
it is an infarct only.
Yeah.
Any angio you've done? Vertebral
No.
artery?
No, sir, no, sir. Patient was not affordable to do any angiography as such.
No, no,
Spinal
MR angiography.
of the spine.
No, MR angiography
Vertebral
of
artery.
vertebral arteries.
I did angio of the brain, which included the vertebral arteries. I don't have the images as such.
How were the vertebral arteries?
So it was normal. I don't have the images of the brain as such.
Okay. No, but vertebral arteries were normal, no? So there was no dissection.
Yeah. Yeah, sir.
Dissection.
Fat suppressed T1 did not show this thing, dissection.
No, sir.
And there was no infarct in cerebellum or
No,
anywhere
sir. No.
else.
MRI brain was normal.
Okay.
So I think it is a discogenic embolus into
Yes, sir.
anterior spinal artery.
Ultimately, I found out there was any relation between the lifting weight and the spinal cord infarct. And the most likely, I found out that it was the fibrocartilaginous embolism, which was the result, which was causing the spinal cord infarct. And the fibrocartilaginous embolism is an uncommon cause of spinal cord infarction, and it is misdiagnosed as transverse myelitis.
Mm.
In these cases, it is a rare cause of spinal cord injury where transient increase in intravertebral body pressure on intravertebral disc, often triggered by minimal stresses, lead to retrograde embolism of the debris into the vascular supply of the spinal cord, typically the anterior spinal artery, leading to the infarction. And unlike the classical etiology of cerebral or spinal cord injuries, infarctions, fibrocartilaginous embolism has a higher incidence in young adults.
Correct.
The clinic in those cases, the clinical presentation in all these 3 cases were triggered by bending to lift objects, suggesting an acute increase in intraosseous pressure with acute disc herniation. And FC appears to be more common than previously thought and should be kept in the differential diagnosis of acute myelopathy in the young. So the clinching point in these cases is we have to take the history of neck pain and lifting weight. That is the clinching point in diagnosis. The distinguishing features of FC is that the patient has sudden and severe pain in the affected spine after lifting weight or trivial trauma, and the onset and evolution of stroke symptoms generally take 15 minutes to 48 hours of the pain after the onset of pain. Generally, it can have poor prognosis and it can be occasionally fatal if there is a medullary infarct.
Yeah.
This is about the evolution of the neuroimaging in the spinal cord infarct. In the acute cases, generally it is seen as a pencil-like hyperintensity on T2 or post-contrast, and initially it do not show any diffusion restriction. While in subacute cases, it shows generally diffusion restriction. Sometimes T2 hyperintense signals is seen in the anterior spinal artery, suggesting slow flow or the thrombus, but the specificity is unclear. This is the T2 weighted and post-contrast showing the linear hyperintensity in the anti-aspect of the spinal cord. This is the representative image which shows the thrombus in the anterior spinal artery. While in chronic cases, differentiating imaging findings from the other causes of myelopathy becomes more difficult. And you can see classical findings of myelomalacia, that is focal T2 hyperintensity and T1 hypointensity, as well as volume loss, that is cord atrophy. And it becomes difficult to find out the actual cause of such chronic cases. This is the chronic cases which shows the hyperintensity in the spinal cord as well as the volume loss. So the take-home message for this is this: consider spinal cord infarct in the differential diagnosis of LATM, and spinal MRI DW should be done in all cases of LATM before labeling it as a idiopathy. Sequential MRI DW of spine should be done in suspected case of acute myelitis, as initial DW images may be normal. This is the video of the patient.
Really improved.
This is after 1 month of the onset of the illness.
See, the recovery is very good. And how long it took for bladder and bowel improvement? How long it took for the
No,
shoulder?
sir. When she showed to me after 1 month, she had bowel control, but bladder control was not there.
Okay. Fine. So the shoulder is still weak, but the legs are relatively better. She is able to walk.
Yeah.
The area where the main infarct burden is there. So right now she has any pyramidal signs in lower limb?
When she presented to me, there was little spasticity was there, and reflexes were brisk.
Okay. Fine. So where
How did
the
you
anterior
treat her?
horn cells are affected, that's a dorsal cord and the cervical cord, that area is still weak. That's the shoulder.
Yeah.
Okay.
So for the treatment, I gave her a steroid actually, because I don't have any what to do with such cases, the line of management. And I gave aspirin also. Any views for the treatment, sir, from your side?
I think steroids must be having some role. The similar way we
Steroid,
think of heart
yes,
embolism, similar kind of
Steroid,
thing.
I would suggest truly, because at least the inflammatory swelling part of them will reduce, and the secondary injury due to the cord swelling and the secondary injury due to further ischemia could be prevented. As it is, in traumatic spinal cord, a steroid had a role, but the doses were much higher. So what doses did you use in this?
I actually gave sir 1 gram pulse steroid dose for 5 days.
I think that's perfectly all right for this child. In fact, this dose could be slightly on the higher side for 5 days, but still okay. That, I think, is a absolutely right decision. I would also take that. Dr. Ichapuria, sir?
Yeah, I don't think steroid is going to help. This is an infarct. I think you have done extremely well. Patient has improved dramatically. And I think good conservative treatment and, looking after bowel, bladder, bed sores, infection, I think that's done the trick. And amazingly, she has improved. And these young children, I think they surprise us every time. They have tremendous plasticity and recovering potential. So, yeah, and I agree with you that it is a discogenic embolus.
Only for the discogenic thrombus, we have to always rule out the other causes also.
Yeah, of course. But the history is so typical. If you take the history, and whenever you get anterior spine, what other cause can there be? It's not atherosclerotic, it's not embolic.
No.
So either it is a dissection because of neck trauma, and you found something in the vertebral body which should not occur with dissection. So everything points, and there was neck pain. She lifted up that 15 kilos, 15 liters of water. So everything, fits in. And I think you've done extremely well for her. And she should bless you for the rest of her life.
Yeah.
Comment on aspirin?
Aspirin, yeah, maybe. But, it's not a plaque which has ruptured. It's an embolus of
Embolus.
fibrous material. So, I mean, aspirin is for prevention. It's not going to treat. I mean, it's not going to, so I don't know. I wouldn't give it. I mean, we give it, because we have to give something, but actually, theoretically, it's of no
Difficult
use.
to justify. Yeah.
Yeah, it is just
I
okay.
agree.
It's harmless, relatively harmless. So let's give it. Rahul, what do you have to say?
I agree that there is no role, there is no atherosclerotic disease documented, no vascular risk factor, and the mechanism seems here to be fibrocartilaginous discogenic embolism. So,
Yeah.
as such, no role of aspirin. Possibly in the earlier stages, maybe DVT prophylaxis because of
But DVT
paraplegia,
prophylaxis, you give LMWH.
LMWH.
Yeah,
Okay.
but the aspirin for DVT prophylaxis, no
I
good.
don't think so.
No
Here,
good.
there is
No
any
good.
role of
So,
aspirin per se.
maybe compression because she's quadriplegic. So,
Yeah.
as I said, she needs good nursing care,
Yeah.
and then the spinal cord recovers. It does recover. It's amazing how it recovers, with even that DWI lesion and that flare
Surprisingly,
lesion.
the recovery
It
was
recovers,
phenomenal,
so there is
miraculous.
plasticity. There's amazing amount of plasticity.
Particularly
So,
the diffusion weighted, they will get recovered.
yeah.
The
So you
flare
just
one,
look after them properly,
yeah.
I mean, that is also treatment. Treatment is not
Whatever.
only giving drugs. Treatment
Yeah.
is also looking after the patient properly.
Yeah.
That is also treatment.
Yeah.
It's not
Whether
necessary. In
the,
fact, the less drugs you give, the better it is.
so whether the
Yeah.
mechanism of stroke, whether the
Huh?
mechanism of stroke is also responsible for good recovery?
I don't think so, because I mean the infarction has been shown. DWI is there, flare image is there, so infarct was there.
See, generally,
But
the three
generally, the blood
modality
supply
of
part
It's
and
not
all those.
ischemia.
no.
It
See,
is. It may not be a ischemic penumbra. Probably it is an ischemic umbra only, but still there is reserve capacity and it recovers.
see, the part which is flare
Huh?
positive, they mean permanent
So
damage.
I think it's a very, very interesting case. And I've seen such a case after a very long time.
Yeah.
So thank you, Dr.
Worth
Tushar.
presenting and publishing.
Excellent case and really well managed, well thought of, and many congratulations to you.
Thank you, sir.
Yeah.
Thank you.
Congratulations.
I would like to just add one point. I have seen another case, sir, which
Yeah.
which she has presented, another young female, which she has presented after 7 to 8 years of the onset of the illness. And the outcome of that lady was, young female, was that only that she had weakness only in her hands.
He has what?
She had weakness only in her both hands only. She had recovered in her both lower limbs, upper limbs partially, but the main predominantly was the dexterity of the hands were involved. She had poor dexterity in both of her hands. So the long-term outcome I have seen in another patient, she had involvement of the poor recovery of the dexterity of both hands.
But she was also quadriplegic.
Yeah.
So the quadriplegia is improved with some small residue.
See,
Yes.
the reason
She's
being
walking.
that
Yeah.
the watershed area of the spinal cord is
Yeah. So
at
maybe
it. It
that is the core
C81
area. Core area is not recovered,
Yeah.
but the surrounding area has recovered.
No, as it is in the spinal cord vascular supply,
Yeah.
C81 area, or there's C2 and this junction, C4 and C2. This junction is an area where you find a level. So that may be something to do with the blood supply of the anomaly that we find, the watershed area in the spinal cord.
Okay.
Yeah.
I think we can go to the next case. Thank you so much, Dr. Desai. Where
Yes.
are you working, Dr. Tushar?
So I'm working right now in Aurangabad. Previously, I was working in Anand, Gujarat.
Acha. You were with Soham Desai?
No, I was not with Soham Desai. I was at Zydus Hospital, Anand.
Anand. Okay. Okay. Great.
Beautiful case. Thank you.
Yes.
Yeah. Thank you.
Dr. Gajanan Patil. Dr. Namra, are you there?
Yes, I'm there.
Yeah, so could you introduce Dr. Bhaviskar again and Dr. Sinha both, because we missed you in between,
Absolutely. There
and
was
Dr.
some
Gajanan
connection
Patil.
problem. Absolutely, I will do that.
Namra?
I would now like to introduce Dr. Prem Kumar Sinha. Sir is consultant neurologist at Inlaks and Budrani Hospital, Pune. Sir is a distinguished neurologist with an illustrious career spanning several decades. He has served as a professor at the AFMC in Pune and holds a DM Neurology degree from the AIMS. Sir is following his exemplary service in the Indian Army and has extended his expertise to the international medical community, spending 15 years in Dubai and Abu Dhabi. He has made significant contributions there to the stroke centers in Abu Dhabi. His primary focus during this period was on administering tissue plasminogen activator for stroke patients. Currently, Dr. Sinha is affiliated with Inlas and Budrani Hospital in Pune and has been using tenecteplase. Since last 17 years, he is practicing as a consultant neurophysician at Nash. We welcome you, sir. Thank you for being on board.
Not Nasik. I'm in Pune.
Yeah, the last line is not correct.
The
Last line is Dr. Bhaviskar's.
Huh.
You have put it in Dr. Sinha's.
Yeah. Last.
Okay, never mind, no problem.
Yes.
Introduce Dr. Bhaviskar, please. Yeah.
Dr. Rahul Bhaviskar is working as a consultant neurologist at Sayadri Hospital, Nashik. He has an experience of 13 years of practicing as a neuroconsultant in Nashik. He is the principal investigator for various trials in epilepsy, stroke, Parkinson's disease, and headache, and has interest in management of headache, epilepsy, stroke, dementia, and multiple sclerosis. We welcome you, sir. Thank you for being on board.
Yeah, I would like to say a few things about Dr. Sinha. I've known him for many years ago, when we were, at least I was a struggling neurologist. I still am. And, he was in AFMC and we used to have very good interactions every 15 days. And, we used to meet and we discussed many cases and many, many things I learned from him. And then I lost touch with him, and only yesterday I came to know that after retirement from the army, he was in Abu Dhabi, and there he was very instrumental in setting up the stroke unit and using thrombolytic therapy. So we welcome you back, Dr. Sinha, to Pune, and I'm sure you will enrich the neurological field in Pune. And Dr. Bhaviskar is a very dear friend of mine. He's in Nasik. He's an extremely good neurologist. And I don't know how he sees 100 patients a day, but he does. And some of the patients I've seen also of his, and he's always spot on with diagnosis. And I really appreciate the work he's doing. He's also, what are you, secretary or treasurer of MAN?
Secretary of Maharashtra.
Secretary. He's secretary of MAN. MAN is Maharashtra's Academy of Neurology, and he's very active in that group. And he's an extremely good neurologist. So I welcome both of y'all and to the show. Dr. Sinha has been here before. Bhaviskar, I think, is the first time. And we really are very happy to have both of you here.
Thank you so much, sir.
Now, will you introduce Dr. Gajanan and then you can start your case, Dr. Gajanan?
Yes, sir. Dr. Gajanan, sir is working as a consultant neurologist at the MIT Hospital Aurangabad. Sir has a credit of publication
you're
on
mixing up everyone. Namra, you're mixing up everyone. Gajanan, anyway, I'll introduce him. Gajanan Patil is working with me for the last, how many years? 10, 15, 10, 12 years. And I must say that he's a very, very good physician. He's a physician, he's not a neurologist. And he's passionately interested in neurology and many, many diagnoses which, neurologists cannot do, Gajanan Patil can do. So I rate him very highly as a neurologist, though he's not an official neurologist, and he's an expert in stroke. And I think independently, he's done more thrombolysis than I have done independently. So we welcome you, Gajanan, and we are very proud to have you here. And you can now present your case.
Thank you, sir. Thank you.
Share your screen.
Good evening, everyone. Thank you so much, sir. The words for me.
Sinha, you have heard this case yesterday, so
yes,
we are presenting it again to a wider audience. But Dr. Sinha knows this case.
Yeah, we have seen this case.
So 35 years male farmer presented with dizziness when he started his motorcycles on 23rd September 24 at 1:45 p.m. Associated with slurring of speech, swaying while walking, and sweating, difficulty in swallowing. He shown to nearby doctor and shifted to Sahyadri Super Specialty Hospital, Nagar Road, Pune. He came at around 4 p.m. Core stroke called after 5 minutes. On examination, BP was 170/86, pulse 72, saturation 92% on room air. He was conscious, obeying simple commands, slurred speech. He had a throat irritation with painful swallowing, left side swaying while walking, right side upper limb, lower limb sensation decrease, left palate movement decrease, left eye partial ptosis, pupils, right eye 3 mm, reactive light, left eye 2 mm, sluggish reactive light, NIHS was 6. CT scan brain, plain. There was no acute hemorrhage, no acute infarcts. So suspecting acute posterior circulation stroke, Wallenberg syndrome, with thrombolyzed with injection tenecteplase 17 milligram at 4:16 p.m. Door to near time 16 minutes. CT angio done. There was left vertebral artery occluded at V2 segments, and there is a retrograde partial filling. There is a in vertebral artery. Blood level was HB 13.9, MCV is 102, LDL is 131, serum homocysteine was more than 50, 2D was LV function is 60%, LSI is 31 millimeter. Any thoughts?
Dr. Bhaviskar, any thoughts?
Yeah, again, dissection is a possibility.
Will it occur immediately like that?
But I think it happened when he was kicking his motorcycle.
He kicked the motorcycle, and as he was kicking, he just, got slurred speech and fell down. Fell down or swaying. So
He sat down.
instantaneous.
Very instantaneous. That is bit odd for dissection. Generally, they develop little delayed embolic phenomena and initial pain. Neck pain was there?
There is no neck pain.
There was no neck pain. Okay.
No neck pain.
Okay. So go ahead, Gajan.
So we did this and just review this ongoing CT angio. We just look after this aorta, and we found there is a large plaque with thrombus 9.7 millimeter into 20.97 millimeter. It is almost 1 centimeter into 2 centimeter length. There is. So now what?
How did that embolus go, Dr. Bhaviskar?
Yeah, that's
Related or unrelated?
aorta distal to the origin of left subclavian artery. It's on the left subclavian. The stroke was also on the left side, no?
Yes.
Yes.
So why not, sir?
The question is whether this thrombus could travel up in retrograde manner or it should only travel forward. Basically, this is a dilemma that a common neurologist will feel. And Dr. Ichhapuria has answered to all this.
Yes, Gajan, go ahead.
So after 6 hours post thrombolysis, clinical patient improved completely. His swallowing and gait improved. Treated with single antiplatelet with low molecular heparin after 24 hours. So final diagnosis we made, there is acute ischemic posterior circulation stroke, Wallenberg syndrome involving medulla with retrograde embolic stroke due to descending aortic thrombus with hyperhomocystinemia.
Go ahead.
The aortic hypothesis mechanism of stroke due to he was trying to start to motorcycle by kick. There's a Valsava maneuver. He developed retrograde emboli from descending aorta to the pica territory. So there was retrograde embolism from descending thoracic aorta causing stroke, which was underappreciated in clinical condition. But this study by Dr. Harlop et al. Using 3D dimensional MRI and 4D dimensional MRI data via uses fusion demonstrated that retrograde flow from the complex descending aorta plaque reaches the left subclavian artery in 67%, common carotid artery in 24%, and brachiocephalic trunk 14.4% cases. The study also reported that retrograde embolism constituted the only probable etiology of retinal or cerebral infarction in 24% of the patients with cryptogenic stroke etiology. The retrograde flow from the descending aorta most commonly reaches the left subclavian artery. Therefore, retrograde embolism most commonly affects posterior cerebral circulation as compared to the right and left cerebral hemisphere in patients with cryptogenic stroke. Some factors that can contribute to retrograde aortic flow and stroke: the aortic plaques in the descending aorta and aortic arch can increase the risk of retrograde cerebral embolization. As age increases, the prevalence of complex atheroma and magnitude of flow reversal increase, and that can cause cerebral retrograde embolism. Also, there is aortic wall insufficiency and decreased heart rate that can cause also retrograde aortic flow and retrograde embolism. There is Hashimoto's et al. Have revealed that most proximal portion of descending aorta can expel the blood in early diastole exclusively upward, and this expel is increased with aortic stiffening. The presence of metabolic syndrome exacerbates the aortic stiffening process, leading to acceleration of aortic flow reversal, leading to mobile complex plaque to detach from the aortic wall and travel retrograde into the carotid or vertebral system, leading to cerebral embolism. There was a prevalence of potential retrograde embolism pathways, and this proximal descending aorta in stroke patient with and controls by Dr. Harlops. He published there is a in 2014 almost 67 patients he shown, and out of that is 44 plaques was in the descending aortic aorta, and that there was number of plaques 1 to 6 segments. The flow reversal connected plaque in the 27% left subclavian artery is almost 61.4% retrograde embolism. As compared to cardiac patients, there were only few patients, 2 to 3 patients. In our case, there was plaque with thrombus is just distal to left subclavian artery and in the descending proximal descending aorta.
Plaque? Because there is calcium there.
There is a calcification here.
Yeah.
Calcification with there is thrombus. So retrograde embolism from the
Go
descending
back to that
aorta.
picture. Go back to that picture, Gajan. And this is the subclavian artery. And
Yes, this is the
you know, that's why it goes into the left. Most commonly, 67%, it goes into the left subclavian artery. So, and left subclavian and therefore left vertebral.
So retrograde embolism from descending aorta visualization by multi-directional 3D velocity mapping in cryptogenic stroke. This is described by AHA, American Heart Association. They found there is a emitter planes are at 1 centimeter intervals from left subclavian artery origin, and this curved green lines showing the antegrade flow, and this blue lines suggest of retrograde flow. As emitter plane 0 at, they found there is a green line suggest of at origin, but as go 10 millimeter later distally, the retrograde embolism chances maximum length of retrograde flow from the up to the 40 millimeter of left subclavian artery. As go little later means 50 millimeter, that chances of retrograde embolism is less. So we treated with single antiplatelet LMWH, high dose of statin, for and follow up after 1 week. He developed. So there is diagnostic modality. Transesophageal echocardiography T suggests study analyzing the mobility of aortic thrombi in the descending aorta, hypothesized that retrograde cerebral embolism would be theoretical possible, especially in case of concomitant aortic wall insufficiency. Though there is T is not able to demonstrate the direct correlations of plaque location and 3D blood flow pattern within the aorta. Multidirectional 3D velocity mapping allows the detailed visualization of physiological and pathological 3D blood flow characteristics and the analysis of the continuation of flow from the distal aortic arch into the supra-aortic vessels. Specifically, in combination with novel MRI protocol for 3D aortic plaque detection, the direct interrelations of complex descending aortic plaques and individual retrograde flow channels was recently demonstrated in their few patients with embolic stroke. So after 1 week follow-up, he developed this index finger, left hand index fingers, bluish blackish distinction with pen. So we started on calcium channel nifedipine with warfarin, and within 1 week he improved. So this was a recent case. Thank you.
Dr. Baviskar and Dr. Sinha.
This fantastic
Yes,
stroke
sir.
mechanism, little
We have seen this case today. So Bhaviskar, we will like to have his comment.
Rahul,
Let's see.
little unbelievable, but I think that looks like the most likely mechanism here. And the later on, the patient developed the finger ischemia also. So excellent stroke mechanism. This is
And
unheard
this
of.
was again on the left hand, is it?
Yeah.
Yes, sir.
No, you know, in cryptogenic stroke, the message also is that in cryptogenic stroke, we must look at the aorta.
Aorta. Yeah.
And, you know, if there is an aortic plaque, which is more than 4 millimeter in size, that is a cause for stroke. If it is less than 4 millimeter in size, then it doesn't really produce a stroke. So the critical thing is 4 millimeter in size. And there was a trial, ARCH trial, which was done by Dr. Pierre Aramenko in Paris. And they analyzed whether you should give anticoagulation or dual antiplatelet therapy. And they found that both were equal. Anticoagulation did not give additional benefit, but that is for the plaques only. Here, I think, you know, there is a plaque, and on top of that, there is quite a big thrombus. The plaque is relatively small and the thrombus is relatively big. So therefore, we made a decision to give anticoagulation, though the trial really didn't show. So, you know, the emboli can be a thrombi, or it can be calcium, or it can be some debris from the aortic plaque. So, it can be, it's not necessarily that it is a thrombus only. It can be calcium also, it can be debris also, and it can be fatty material from the ruptured plaque. And probably that kicking the motorcycle produced Valsalva maneuver, and there was backflow, and it went into the vertebral artery. But he was a little far away. He was Gajan, how much? I
40
think 40 kilometers away.
40 kilometers.
40
40 kilometers.
But luckily he came in time, to the hospital. It occurred at 1:30. He came by 4 o'clock, and very quickly we could thrombolize. Initially, he didn't improve, but then very quickly he improved and he became totally normal. And his bulbar weakness improved. His, he couldn't perceive hot cold on the right side of the body. That also improved. To our great surprise and delight, the hemisensory loss of Wallenberg improved completely, and even the ataxia improved. He was very ataxic, really ataxic on the left side. So all that improved. So overall, we were very happy. And also, we must remember this retrograde embolism. I had heard of it many years ago, but I was waiting to see a case. And finally, after many years, I could see such a case. So we thought that we should present it because it's an important thing to remember. It sounds, when I first heard it, I was very skeptical. How the hell can it go from the descending aorta into retrograde? But it happens. And, somebody's done this very fantastic MRI study, and it shows that it goes this thing. And especially with aortic regurg, if you have aortic regurg, definitely it goes quite a bit. So even without aortic regurg, it can go. And this is an important thing to remember for everyone. So thank you very much. Dr. Sinha, any closing comments?
They could do the tenecteplase fast.
Little loudly, we can't hear.
They could give the tenecteplase very fast.
Yeah. 16 minutes, door to needle time.
So that is a time is brain. That's important.
Exactly. So that is another message,
You could have been out of window.
Yeah. So quick CT scan and angio to be did after we gave tenecteplase.
And there are people who waste time that I will do MRI, I will do this, then I will do it. There is no infarct is being seen. In one of my patients, the CT, patient had a frank stroke. We took a video, gave the thrombolysis patient, and then we sent it for angio. The angio came clear. Now the insurance company says, oh, angio is clear. I said, look at the patient video. We treat the patient. Patient video is there. This is a CT normal. This is the criteria for treatment. He is treated. He has recovered. Because it is done later on, it has opened up. So one of the doctor was telling that I do MR angio so that I have evidence. Manka, don't wait for evidence. Treat the patient, save his life. Second area is to do angio. So give thrombolysis. Subsequently, you want any more investigation, you do it later.
The most common CT finding in acute stroke is a normal CT scan.
Normal CT. And that is what we are
looking. You don't have to see the infarct.
Yeah.
If you see the infarct, maybe you're too late.
Yeah.
So the commonest finding in acute stroke, acute ischemic stroke on CT scan is a normal scan. And you have to see clinical radiological mismatch. And if you see that, it's enough to give thrombo. You don't have to do MR, this, that, diffusion, flare, angio. It wastes half an hour, 45 minutes. So you miss the window. So Gajanan was on the floor, and within 16 minutes, I think he could give it. So that is to his great credit.
That's very creditable.
Yeah.
Wonderful.
Okay. Any closing remarks, Dr. Bhaviskar?
Yeah, I think today's both cases were very interesting and very unusual stroke mechanism, relatively rare stroke mechanism.
Yeah.
Very nice cases and well managed by Dr. Gajanan. I think best part was he thrombolized it on time. That is the best part of it. and recovery in both the patient was definitely good. So that is also rewarding. In both the cases, patients recovered significantly well.
Yeah.
Very good cases.
Excellent. I do agree. Tushar, your case was also excellent. Gajanan, you have also done a great job. So well done, both of you young guns. We want more
Thank you,
young people to do thrombolysis.
Yes.
More young people should
More,
do.
more, yeah.
Huh?
More.
You don't have to be a neurologist, yeah.
I remember
Everyone can do it.
in 2007, I picked up an old man who had collapsed in a Ganesh Puja and he could not write. So I knew he has a stroke. I picked him up to Dr. Ichhapuri at that time because he was a civilian. I couldn't have treated in my setup. And next morning, he was sitting and eating food with his right hand. That was the beauty. I
Yeah.
always remember. And I wonder whether you remember in Jahangir Hospital.
Yeah.
Yeah, I spoke to you.
Yeah. So there are amazing success stories with thrombolysis. Amazing. And it is really extremely gratifying to treat these patients, I mean, I wish more people do it and more people, restrict to early door to needle time and be aggressive and be little bold. People are scared. So, little boldness is necessary. And I think it's a wonderful treatment,
Wonderful.
for
Wonderful.
stroke.
And tinactinase
Yes,
has
Dr. Namra.
really
Yeah,
much
sorry.
simpler. Tinactinase administration
Yeah.
has made it much simpler.
Of course.
And I personally feel with the experience, it is a bit more effective than what I felt with the TT.
Absolutely.
I don't know whether you agree with this part, but I feel it's a bit more effective. We get a faster things, easy to administer in one bolus. And that's very good.
Yeah.
Right, sir. Thank you.
Yeah, thank you. Dr. Namra, could you close the session?
Yes, sir. Thank you so much, sir, for providing time for this meeting. We are really grateful and thankful to you for the same. I would like to thank Dr. Rahul Bhaviskar, sir, and Dr. Prem Kumar Sinha, sir, for your valuable insights. Certainly, many budding neurologists, physicians all over the world may benefit from these sessions, which is our motto. We would like to thank Dr. Gajanan Patil and Dr. Tushar Desai, sir, for their valuable contributions through the case presentations. Today, we are live with the 350 plus attendees, sir.
Oh, great.
How much?
350.
350. Usually we cross 400, but 350 is also very good. 350 people do benefit, so it's a great thing.
Thank you so much.
Thank you.
So I conclude this session. We will get back with another interesting session on no thrombosis workshop series on stroke. Till then, have a good day.
Thank you. Thank you, everyone. Thank you. Bye.
Recording stopped.